disorder sexual development, which is a common presentation with a lot of confusing scenarios in terms of evaluation and management. A complicated process in terms of how a unicellular structure gets the complete gender development. So we all know that, of course, in the initial phase, the development is absolutely normal. And towards the end, we have the gender identity, which is established. So there are multiple levels of control, and you can have abnormality at any level, which can cause these problems from that perspective. So this involves a combination of genetics, gonadal differentiation, and gonadal development, development of hormones, their receptor, and finally the external development, which will result in the phenotype and the gender identity. Any discrepancy between the genetic, the gonadal, the endocrine, and the external manifestations will result in a disorder of sexual development. And there are a lot of names which keep on changing in that regards. So we all know that we now talking about more in terms of differences in sexual development rather than disorders, because that will have a negative connotation in that regards. The development happens from the urogenital ridge, from which you have got the gonads, along with the development of the kidneys using the WT1 and the adrenals using the NR5A1, which is there. And you have got the adrenal, which produces the androgens, making it very important from the perspective of XX-DSD or acts of commission. From this, you have got the bipotential gonad, which develops under the influence of SRY and SOX9 into testis, where LHCG receptor controlled by the LH and HCG act on the Leydig cell to produce testosterone, which is converted via 5-alpha reductase to DHT, acting on the androgen receptor and causing the virilization and other features. On the other hand, we have got the FSH acting via the FSH receptor on the Sertoli cells to produce AMH, which is going to knock off the Mullerian structure and produce a ground for production of the Wolffian structure from that perspective. On the other hand, in the absence of SRY, SOX9, in the presence of FOXL2, DAX1, you've got the ovarian development, which is largely a passive process but supported by various genes, wherein you have got the theca cells which produce androgens, and the FSH-regulated granulosa cell, which produces aromatase to produce estradiol. Estradiol will act on the estrogen receptor to have an effect in terms of development of the Mullerian structures in that perspective. So if you think of it, you've got this bipotential gonad, which basically is then being taken, developing into testes or ovaries, producing the various hormones, acting on the receptor to cause these effects from that perspective. Now, in this regards, you can now classify DSD into various forms. You can have a problem in terms of the development of the bipotential gonad, starting from the WT1, in which you will have a renal involvement as well in the form of a Dennis-Strass syndrome or Frazier syndrome. Problem in the adrenal development, which is the NR5A1, which is defective. Abnormalities in the SRY pathway, which will result in, if you have insertion of SRY, you will have a XX male. If you have deletion of SRY, you will have XY gonadal dysgenesis. SOX9, which will again going to cause the important cause of XY DSD, along with skeletal manifestations. You can have a problem of overexpression of DAX1, which is going to cause again a XY DSD from that regards. Increased production of adrenal androgens is going to cause CAH and XX-DSD, as we've discussed from that regards. Now, within the ovarian axis, as we discussed, you need to have an act of commission to really have a problem. So here your problem will be aromatase, which will produce more androgen and cause virilization, while at the level of testosterone biosynthesis and action, you can have huge number of problems which can cause these scenarios, starting right from LHCG receptor defect to a scenario of 5-alpha reductase, which is converting testosterone to DHT, a problem in the AMH gene or the AMH resistance, which is going to cause a Mullerian structure which will be present in that regards, and of course problems in the androgen receptor causing androgen insensitivity syndrome. And of course, if you have a problem in the Leydig cell, you will have a problem. So we have tried to figure out the various forms of DSD, and now I think this will become a very important slide to really focus on in terms of whatever we have learned till now, is that DSD can be classified, broadly speaking, based upon the genetic composition. You will have a XX DSD, which is characterized by lack of palpable gonad and the presence of Mullerian structure. So in XX-DSD, it's usually because of too much androgens that you have, and this androgens can come from the adrenal. So you've got the CAH variant, the 21, 3 beta, 11 in POR. They are all going to cause your androgen excess, or ovarian production, namely coming from the aromatase deficiency, rarely from luteoma. But if you have a luteoma of pregnancy, as we have discussed, the placenta will try to take care of it. If it gets overwhelmed, if your placental 17 beta HSD is overwhelmed, like in severe forms of Cushing's, your 11 beta HSD activity is overwhelmed and you develop hypertension, hypokalemic alkalosis. Similarly, you will have that, but otherwise it will be taken care of. You can also have problems in XX gonadal dysgenesis like SRY, SOX, and FOXL2, which will also cause a problem. This group of XX-DSD due to adrenal androgen excess are by far the most common forms of DSD and the most life-threatening. So that will be the 21 hydroxylase deficiency. Others are relatively rare. The second group will be the XY-DSD. So you have got the gonad, and the gonad is producing AMH, so you don't have a Mullerian structure. This could also mean a scenario in which you do not have the gonad, but you also do not have a Mullerian structure, which basically means that at some point of time gonad was there or it is intra-abdominal. Now, XY-DSD could be because of a complete problem in the gonad. Your gonads did not develop, NR5A1, WT1, SRY, all those scenarios, or your gonads were there, but they are not producing enough DHT. So problem could be in the star, side chain cleavage, 3 beta HSD, 17 hydroxylase, which will cause hypertension. The first 3 will cause salt wasting, 17 beta HSD and LHCG receptor defect, which will not cause any salt effect, or a problem of post-testosterone conversion into a dihydrotestosterone or androgen insensitivity syndrome. Then finally, you can have a more complicated picture of sex chromosome DSD, in which you have got both gonad as well as Mullerian structure. So you will have either a problem of post-zygotic fusion, in which 2 particular gametes have fused. So you will have XXY, XYY, that sort of a phenotype, which we'll discuss one of the cases in that regards. Or you can have a post-zygotic error in terms of mosaicism, which can cause these problems. And this will include testicular, over-testicular DSD from that perspective. So if you now remember this basic slide, which talks to you about how do we classify DSD based upon this 2x2 table of Mullerian structures as well as the testis, and then based upon classifying into XZ and XY, you will get the diagnosis right.